Wow, that's good, because I'm actually a little scared after everything I've heard. Like, mine is going to be dull as sticks, and I'm going to really try and keep you awake with this stuff, because like tissue banking and everything else, that's sounding very important. And you know what I'm going to do is give you a little fluff on the Canadian system. So a little bit of background. So we're going to do, this is like a little interaction, National Healthcare Databases 101, the Canadian perspective, right? So I'm lucky, I am an American citizen, but I'm a permanent resident of Canada. So I have access to this wonderful thing called universal healthcare. I also have access to like Tim Hortons coffee, which I'm really missing today. You know, RCMP, the Mounties, it's nice to see them riding around, all the good stuff. But a lot of people think, wow, universal healthcare, that's the first thing they're going, wow, you're so lucky. It's like, you know what? I am really lucky. If I get hit by a bus on the way back to the hotel, you know, if something, God forbid, happens where I need tissue donations to my own bone marrow, I don't have to worry about losing my house tomorrow. It's covered. I can go to whatever doctor I like. If I don't like it, I can go somewhere else. So what we're going to do is, I'm not going to talk about that though. Even though you're probably interested, wow, how do we get that? I'm not going to talk about that. You know, there's healthcare reform coming. You're getting closer to Canada, and it's funny, because out in Alberta we have activity-based funding starting up. We want to be like you. But the key thing that I want to talk to you a little bit about is there's healthcare delivery and data collection, and it's funded federally and provincially and territorially. So federally, you know, the whole big bucket, and then we've got the 10 provinces and the 3 territories. So how's it taken care of? Income taxes, really high income taxes. Okay, so you take home more than I do, but I won't lose my house if I get sick. So there's a catch. And what happened here is when you're delivering services, they realize that they actually have to kind of collect the data. So what happened is the Canadian Institute for Health Information, or CIHI for short, was created by a mandate by the Federal Ministry of Health and the federal and the provincial ministries of health. And they were created to become really the collectors, gatekeepers, and disseminators of the Canadian healthcare information. And the main reason they do that is so that they can kind of have an integrated approach to health information systems. And you figure if you have an integrated approach and standardized collection, then perhaps you can have better effect with the healthcare system, and in the process, a byproduct is have healthier Canadians. It's a non-for-profit organization, non-partisan, at arm's length from the government, because the only way you can make sound decisions is if you're not biased by somebody twisting your arm saying, we'll give you $10,000 more, 10,000, that's silly, $10 billion more if you tell us what we want to hear. So we are, even though we're funded mostly 70 to 80%, and when I say we, the healthcare system, I forget I'm new with MicroStrategy, but I used to be with CIHI. It's 70 to 80% funded federally and provincially, and another 20 to 30% from third parties, researchers, and so on and so forth. The main mandate of CIHI was to develop and maintain some national health standards, to manage health databases and registries, and to provide objective and accurate analysis of the data. So, I mean, this is the big piece. Now we're going to talk about is that there's 26 national databases and registries. And when I say national, we're coming from, this is everything, with a few exclusions from Quebec because they do things a little differently there, but we're working on them. We're twisting their arm a little bit. And the 3 key areas are health human resources, healthcare spending, and health services. Now, the 2 that we have up here, the health spending and human resources, these are non-patient identified. So there's no patient identifiers in these. In our health human resources, we've got directories on every occupational therapist, every doctor, every dietitian. It's all there, what their credentials are, how long they've been practicing. It's good stuff. You want to know, it's there, and it's public. You can get at this stuff. Then we have our national health spending. You notice there's just 2. Makes it easy when, you know, the universal health care. And so the Canadian MIS, that's financial and statistical hospital data, versus the national health expenditures is the whole conglomerate. What's being spent public sector, what's being spent private sector, how much in pharmaceuticals, how much in personal home care. So that's the big piece. And then the health services database, this is the good stuff. This is the patient identifiers. It is standardized, it is national, it is collected. Big ones like inpatient, from acute care hospitalization, to organ transplant registries, to cancer care, to even global international, like what's Canada doing so we can submit that internationally. And what are the benefits? Well, there's a lot. I mean, obviously, we span the continuum of care. You'll notice there was a gap. We're working on a primary health care database because that's a huge gap between ambulatory care and hospitals. We can support clinical research and evidence-based best practice, and when you do that, it will give better decision-making, and you can do new policy development and fill gaps. It simplifies comparative reporting. It's apples to apples. You're all reporting the same stuff, and there's huge data. The data quality in the acute care inpatient stuff is crazy. And even some of the newer ones, the National Ambulatory Care Reporting for emergency care, same-day surgery, and outpatient clinics, they've set up rules that if you don't meet the data, we'll let you send data with warnings, but if it's got an error, we reject it. Fix it before we'll accept it. We want it clean. It's reliable, it's quality, there's controlled access, but there is public access via quick stats and actually access to the people who provide the data, and it's private, confidential, and secure. And if you're looking for more about it, you can come talk to me later. Have a nice evening.